Welcome to the first Mass General video flare, which assesses the rapidly evolving literature on SARS-CoV-2 and COVID-19, here on the new inflammatory syndrome involving children. Special thanks to Boston Children's Hospital cardiologist Paul Estezo, MD, PhD, and Kevin Friedman, MD, and the FLARE team at MGH. Children are presenting with a severe illness similar to Kawasaki shock syndrome and associated with COVID-19 infection, called pediatric multisystem inflammatory syndrome, and sharing some similarities with Kawasaki syndrome. The majority of children are 9 to 10 years of age with severe cardiovascular involvement, elevated biomarkers of cardiomyocyte injury, and shock physiology. First, a quick review of Kawasaki disease, an acute pediatric vasculitis involving medium-sized vessels. Kawasaki often has a genetic underpinning and infectious trigger, thought to be a delayed inflammatory syndrome. Kawasaki may have cardiovascular complications, including a short-term shock syndrome and long-term development of coronary artery aneurysms. Classic diagnostic criteria include 4 to 5 of the following: persistent fever over 5 days, mucocutaneous involvement, non-purulent conjunctivitis, polymorphous rash, unilateral lymphadenopathy, palmar-plantar erythema and desquamation, evolution to a KD shock syndrome in 5 to 10%. Most PMIS children present with a Kawasaki disease-like inflammatory syndrome and wide spectrum of illness, with the sickest developing shock and respiratory failure. While most patients improve, a few fatalities have been reported. Fever greater than 38.5 degrees, 80% had gastrointestinal complaints, 28% had comorbid illness including obesity, and 17%. Asthenia was common. Lab tests: elevated inflammatory markers, D-dimer, fibrinogen, IL-1, IL-6. Cardiac: NT-proNB elevated as an indication of heart failure. Echo, LV dysfunction. SARS-CoV-2 tests: PCR, serology. Treatment is modeled after Kawasaki disease, though no standard therapy has been established and there is almost no data to support it. IVIG, intravenous immunoglobulin, the dose generally 2 grams per kilogram, is most commonly used due to its broad immunomodulatory effects and well-established first-line therapy for Kawasaki. Aspirin, immunomodulatory medications including corticosteroids, tumor necrosis factor alpha blockers, IL-1 inhibitors, and others. Small numbers require VA ECMO. Medium age is 9 to 10. There are several series indicating a current or past COVID-19 infection. Papa Giovanni Hospital reported 10 patients. Positive nasopharyngeal PCR tests for SARS-CoV-2, 2. SARS-CoV-2 serology, 8. France and Switzerland reported 35 patients. Positive nasopharyngeal PCR tests for SARS-CoV-2, 12. SARS-CoV-2 serology, 30. We've seen that PIMS resembles many features of Kawasaki disease, which is thought to start with an innate immune response to a particular antigen and then progress to a hyperinflammatory state. Support for a post-viral autoimmune process comes from serologic studies. Let's look at the French and New York City series. French: 30 of 35 patients, positive serological assays. 23 at IgA and IgG, 3 at IgG, 2 at IgG and IgM, 2 at IgA only. The high prevalence of IgG and low prevalence of IgM suggests that SARS-CoV-2 infection was not recent. The delay between the peak of the pandemic in the general population and the emergence of PMIS is also consistent with the hypothesis that PMIS may be a delayed syndrome after recovery from SARS-CoV-2 infection. The emergence of the 50 cases in New York City and Long Island a month after the COVID surge in New York City also suggests that this is a post-infectious immune response. Summary: the emerging but rare COVID-19 associated multisystem inflammatory syndrome in children resembles Kawasaki disease in its presentation, management, and likely post-viral etiology. Fortunately, with appropriate treatment, the majority of patients appear to make significant recovery, though long-term sequelae have yet to be determined. Thanks again to Boston Children's Hospital's cardiologist Paul Estezo, MD, PhD, and Kevin Friedman, MD, and to the FLARE team at MGH.